But this is how I and Patty organize our thinking, right? Our cognitive structures around what goes into a pediatric evaluation. And so as we move through these slides, you'll see that we spend more or less time on different things, right? Depending on what we can get out of them and their complexity. So, all right. So first is records review. I've got this kind of 7-step outline that we're using to organize our thinking is up there, so you can come back to this or find kind of some footing here. So whenever we have any type of new referral evaluation, I want to know what's been done before, right? And so is there any available medical information? Usually you can get birth history. If it was a medically complicated birth, that there will be some type of history. If it wasn't a complicated birth, there isn't going to be much there to go on. You want to ask, do they have any previous experience with OT? That's pretty obvious. To the extent that children have engaged in either birth to 3 or preschools or Head Start programs or actual schools, there'll be some academic records, right? So what are those academic records, and can we get our hands on those? Again, in the context of schools, have they done standardized tests? I don't know what age standardized testing starts here in Colorado, but in Ohio, I think there are even K4, like standards that they're being evaluated on. So kids do develop a file or paper trail that you can look at. And so start there. And one of the skill sets you bring because of the training that you have is some of the statistical stuff. And I know that's probably not why you got into OT, but 3 research classes, right? You had to take a stats class to get in. You do have this knowledge, and relative to other members of the team, I would suggest that you potentially have more than some of the other members of your special ed team. That may not be true in all cases. Right, psychologists and social workers and special ed teachers with their master's degrees are certainly doing this as well. So a couple things that I like to keep in mind, right? If we're talking about a standard score, like an IQ test, so when you hear standard score, I want you to think IQ. Those have means of 100 and standard deviations of 15. And so really quickly, off the top, we know that 68% of a normal population of people will have standard scores between 85 and 115. Right, that's the bell curve. So between 1 standard deviation below and 1 standard deviation above, 85 to 115. That's 68% of the population. So that 95% is within 2 standard deviations. That's where like P equals or is less than, right? Is less than 0.05. That's where statistical significance comes from. So if the data we observe is outside of 95% of the population, so beyond 2 standard deviations, either above or below, and then 3 standard deviations is pretty rare. And so we layer on this thinking, and when we encounter data, really quickly, we've got a kid that scored at 80, let's say, on a motor eval. Immediately, we know that they're a little bit below average. That's all we know. But if you can become comfortable with this, you really will have a leg up for some of these skills. How you're interpreting the data, what you make of it, how you use that to organize your eval and communicate with your team members. All right, so records review. Dig in and learn what you can. This next one is, well, it's kind of simple. It's based on what you've been able to collect, based on those records, based on what you're able to find. Start putting these things in context, right? Are the skills that you're seeing, right, is the documentation that you have indicating that the skills are developing typically or that they're a little bit delayed? And so these here are just examples of kind of like common language, right? So we're talking about some skill or some occupation. He demonstrated the ability to wipe his butt and pull up his underwear and pants and snap the button. These skills are typical for a child his age. So that type of thing. That's the interpretation. We can report the score, but one of your skill techniques is to be able to do this interpretation for folks. So, NBCOT question. You're working with a 10-month-old who has started to cruise while holding on to furniture. How would you document this child's development? Right, so this is a milestone in the context of exploration, probably exploratory play. So when are babies typically walking? About a year. Babies are walking at about a year of age. So if we're cruising at 10 months, what do you think? We pass. So here, this is an example of how we would use this type of knowledge in context. All right. So next up is interview. So certainly parents, and then depending on the age and how involved the child's history has been, you could have teachers, other professionals, members of a medical or rehab team. Absolutely, as kids get older, we have to be empowering them to speak for themselves, right? And then whoever else has the information that you need. And so within that, I try to think of a few guiding questions, right? So what is it? Why am I here? Why are we talking about this? What's going on? And how can we be helpful? So I think that's kind of a broad, arms wide open approach. What's going on? What are your concerns? And how can we be helpful to you? And so depending on parents, child's parents' teams, familiarity with OT, you're going to have to do more or less explanation in terms of what pediatric OT can help a child with. All right, so some principles for interviewing little kids. I feel like you need to have an asterisk because right, that's a whole thing. Self-report of children is something that is tenuous, and so very often in research we try to verify what a kid says with a parent interview. So be respectful, talk to them about why you're sitting down and why you're asking them questions, ask them reasonable questions, try not to let your biases show through too much, right? Kids are impressionable, they'll repeat what you say. Ooh. Keep the projector on. So, yeah, impressionable. as an example, I was working with a little kid with autism once who would perseverate and do echolalia, right? So he would get stuck on what you said and then would echo it back over and over and over. And so we were doing, I don't know, a fine motor game one day, and I'm just sitting there doing my documentation, and I said under my breath, oh, that's a good challenge, to myself, right? And I was just noted, like, I'm on the Just Right challenge, right? This kid is working hard, you know, the activity is at his level, and we're in the sweet spot right now. And so this kid just repeated it for the rest of the course of treatment. So when he felt he was working hard, he said, that's a good challenge. This is that multiple ecological assessments or observations. So not just one data point, but shoot for multiple natural setting data points, right? And then you do a triangulation. Are these data consistent? Are they congruent, or are they not? And that when you find that can be very informative, right? When people have different perspectives. Knowing what children will do or say at various ages to verify information. So that's more of cognitive development, right? And so as we talk about developmental milestones, we're not really getting into cognitive development or executive functions until later in the semester, right? But that's a whole system of, kids will tell us first what they're thinking, right, with their eyes. By looking, then babbling, and then increasingly more complex forms of communication. Positive terms, simply, be flexible, interactive. So those last two speak to me, thinking about doing evals with kids with autism, right? Calm environments, keeping things simple and predictable, but then also being flexible, right? So that when we have a tantrum or things are blowing up, that we're not overreacting and telling them, don't do this, or no, 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 right? We can say, yeah, let's go take a break, and then we'll come back and play some more. How do we weigh parent and caregiver report? So the first part is that triangulation. So are the data that we're collecting lining up or not? We ask clarifying questions, try to bracket our biases or assumptions, and frankly, that is it's very hard. We all carry unconscious biases, and they affect our behavior in ways we're not even aware of. So to the extent that you can try to start your new interactions, your new relationships, being respectful and open-minded, right? If you get a hint that maybe someone's from a different culture, that you take a step or two, right? Make at least an initial effort to think about what might be relevant.
Can I just add in there that
Yeah.
when you're speaking directly to parents or writing something that they're going to read, I find it super important to start with this is not your doing, because if you don't acknowledge that this is not a parent's fault that the child is experiencing these things, they won't read or hear anything else you have to say, so the rest of it is absolutely useless. So that's your entry point.
Yeah. So comment was, to be supportive and communicate, right? That potentially developmental delays, those types of things, right, aren't parents doing. And so absolutely validate and want to and hear that. The one thing I do want to mention, though, and it's a tangent now, but it's relevant given the comment, is the hardest stuff I've ever done in pediatric rehab is when it is the parent's fault.
You can't start.
You're right, you cannot start there.
That's true, that's-
But when you look at parents who are using drugs when babies are in the womb and developing, or right, non-accidental trauma is the term that would get used in a children's hospital, but that really just means child abuse. So maybe you'll get me to cry later in the semester about that. That is hard stuff to do. But some of those principles, so tied back to some of those slides, right? Being strengths-based, right? So even if there are some awful things going on with the family, what's going on that's positive, being strengths-based. Trying to leave their assumptions at the door, right? What's going on and how can I be helpful to you? Approaching things from that perspective. Interviewing parents of a 4-year-old child with mild CP. Child is regularly fed by the caregiver and does not demonstrate independent feeding skills. Before setting the goals, what should you explore first? Abnormal muscle tone.
Cultural context and family dynamics.
So cultural context and family dynamics. Why do you think that would be appropriate?
Because my sister has CP and she's perfectly capable of feeding herself, and whenever I'm home she does feed herself. And my dad just insists that it's faster and easier for everyone if he just feeds her. And she's 32.
Well, and he may not be wrong either, right? Your dad?
Yeah,
He's probably not wrong.
that's his contact. It's easier for
Faster and easier? Yeah, so that's absolutely right. Depending on an individual's context and what's going on with them, there could be all sorts of different things going on. So as I see 4-year-old, I'm expecting higher level skills, and then I see fed by the caregiver, and that's an incongruity, right? So that's a red flag. So there is something there. A 4-year-old should be much farther, not should. A typically developing Western child would be much farther along the developmental sequence for feeding, eating, swallowing, right? Would probably be getting, maybe even starting to do some cutting, 2 hands together, right? So I think that's a pretty good example. Something that maybe is more like culturally influenced. There are certainly different cultures, ethnicities where kids are held till this age, right? And breastfed until this age. And so in that culture, and in that context, this is not atypical. And so we do have to recognize that we are putting our own Western medical lens on development here. Please.
As an example,
Yeah.
this summer I was working with refugees, and so one of people's daughters was like 9 years old, and they're from Myanmar, and so I would go to their house and my mom would be feeding her rice. It was just so chubby to come out. And she's 9, and she's lived in the US for like 4 or 5 years, so she knows that it's maybe not cultural. She kind of was embarrassed, but that was how it was.
Yeah, right. So, I mean, folks who are new to our country and communities aren't ignorant necessarily that their practices may be different than ours. And so creating an accepting and safe place, right? It would be unfortunate if, say, mom was hiding that behavior when we went into the home, right? Because of shame or because some disconnect about how we were going to judge her based on our expectations. So, looking at this one, degree of abnormal muscle tone, bilateral upper extremities. Can you remind me what your name is? Ashley. So similarly, working in high schools, high schoolers with CP, as kids get older, it's very common to get an implantable baclofen pump, which will manage spasticity around the clock, as opposed to going in for Botox every 3 months, which has decreasing efficacy over time. So one of the students I was working with, a 16-year-old woman, got a baclofen pump, and her spasticity just went way down, which made it harder for mom and dad to do transfers at home. And so while we felt good that she was probably in less pain because of the spasticity and potentially deforming positions, the medical advice caused some issues at home, right? So we had to figure out, some new lifts or new techniques. The way that they were doing things was not going to work anymore. So you need to observe performance. Again, this is going to be highly context specific, right? If a kid's in a hospital, you've got the hospital room, you probably have there's usually a playroom on every hospital floor, and then you have the hallways. That might be it. And that's assuming the kid can leave the room. So that, I think that would be best case scenario for someone who's medically fragile in that type of setting. But then depending on the child's age, if they're in school, if they're in preschool, receiving services at their home, then we want the sky's the limit, right? That's that multiple ecological context idea. So the types of, maybe a hospital has a playground, right? So in the summertime, you go outside or across the street to the park. Working in the Peds clinic in Madison, I took kids to the park across the street from the clinic all the time. Those specialized environments that, right, you're probably just in that one room. That's the context of that environment. But then as we get into older ages, and you think about school settings, really thinking about all the different environments that a child encounters during the school day, right? And it's more than the regular classroom. So hallways, bathrooms, lunchrooms, playgrounds, etc. And then all the transitions in between. And so you do not do every one of these, but depending on your review of records, depending on your interviews, your observations of performance, or now you're going to start diving in. Does that feel straightforward enough to you all? For me, in working in a school-based setting, my kind of rule of thumb was 2. I always wanted 2 environments, and then within that 2, I tried to differentiate a special ed environment and a regular ed environment, and that's not always possible, right? If this is a totally new referral evaluation and this child has no history in special ed, they're not going to be in a special ed room or environment for you to go observe. But for those that have been in special ed, and again, so that the special ed environment would be any pull-out environment. So any environment where the child with a disability is being segregated from where the rest of his or her class is or would be. What makes that observation skilled? So we're great at task analysis. That's one of our skilled traits. So being able to document that systematically, being able to interpret those data in a intelligible and valuable manner. And it is able to kind of situate their interpretation analysis in the larger context of physical environment, cultural, social context. All right, we are just about to jump into standardized tests. I think this is a good time to take 5 minutes. That sound all right? So please, let's start again at 155. All right, we're back at it, and now we're diving into pediatric standardized assessment. So there's a sheet coming around with just a question of a prompt. What are some of the unique aspects of OT assessment in pediatrics that are distinct from adults? We're not actually talking about that at this moment, but I do want you to be thinking about it. So here are some of our uses for standardized tests. I think number one there, for me, is probably one of the biggest points of differentiation. It's not necessarily to say that assessment for adults isn't about eligibility, but eligibility and then medical and or educational diagnoses are kind of unique things, or that language is being used very specifically in the context of pediatrics, right? In the context of birth to 3, early intervention, and then school-based special education. Eligibility is part of the special ed process. We'll talk about that. And then, so that eligibility gets tied to an educational diagnosis. It's not really a diagnosis, eligibility area, educational eligibility area. We also use assessments to monitor progress in therapy, to give us data that we can use to plan, set goals and then plan interventions, monitor outcomes, and then research studies. This bit here, I think, well, some of it will be familiar, and maybe other parts new. So I think this is the familiar part. Why is this child referred? What are the child's occupations, and where are we seeing some difficulties, and what can we help you with? So I hope that part feels familiar, and then we use assessments to kind of fill out the rest of the data. So from that occupational profile and analysis of occupational performance, what medical, developmental, what areas do you need more information on? Thinking also about what are the requirements, what's involved in doing a standardized test, and how does the assessment tool that you pick complement the other things that you've done. I think I've said the word triangulation a couple times today now, but that is important, right? If records are telling you one thing, an interview is telling you another, well, can you then pick assessments that will help you sort it out? So being thoughtful about the assessments and how that's going to then fit with the other data that you're gathering. Supportive testing environments for young children. So one, I don't know if it's, the first one is about you. And so being competent in the assessment that you're going to use will reflect in your confidence, in your demeanor, and the rapport that you're able to establish with a child. So being prepared to do the assessment is foundational. Sensitive to the needs of the child and family. So, if maybe I have a plan to do my eval in an exam room, with, it's quiet and there isn't too much on the wall, there aren't many distractions. But perhaps mom and dad come in and they have 2 other kids in tow, plus the kid that you're there to evaluate, and we need to talk to mom and dad to get data from them, and so kids are coming along too, right? So how do you do the standardized assessment now when you have 2 or 5 more people in the room than you thought you were going to have? Be friendly, interesting, informative. The impact of the testing environment, right? So on one end is that confined room, nothing on the wall, it's quiet, no distractions, perfect for standardized testing. But again, it's not natural. And then on the other hand, I can't really do a standardized assessment in a classroom while the teacher is doing a language arts class, right? So being that ecological is not workable either. Build rapport first, right? So I'm always just playing with kids immediately, right? I'm potentially even before I'm getting into those questions of, so what brings you in today and how can I be helpful to you? I'm just playing with the kid, right? I'm on the floor immediately with them. What toys, right? What do they touch? What are they reaching for? Just to give me a feel for where they're at. So then I think the other thing I want to highlight off this slide is, to the extent that you can, maintain standardization. And we'll talk about this, but the assessment is either administered in the standardized way, and if you do that, you get access to all the data and the normative sample and all that stuff, or it's not. Right? If you deviate from the protocol, it's important to incorporate that into your interpretation as well. Ethical responsibility before using a standardized assessment. That sounds pretty heavy. Common sense before using a standardized assessment. So know it. You got to read it, understand it. How many of you administered standardized assessments on your level 2? Okay, so definitely the majority. How many of you had to prep to do that standardized assessment by studying at your kitchen table or your living room floor, right, the night before? So you have to learn it. You have to know what you're doing. Ideally, you want someone that has this in the bag already to learn from and to mentor you, right? So that as you're just getting started, maybe you just watch the more senior therapist do it first. And then you test it out on your friend's kid just to get some experience with the items. And then you use it for the first time in a clinic, but it's not for an eval. Then you ask that senior therapist to watch you do it. Right? And so there are ways to go from 0 to being competent to do these. Practice the assessment before giving it. That is awkward, especially with little kid assessments. You're going to get to do that a bit tomorrow in terms of administer some assessment items to each other. But it's the best we can do most of the time. Keeping reliability and validity in mind. So how much does that matter? Well, if an assessment has crap reliability and validity, you shouldn't use it, and you'll look silly if you write up that assessment. If that ends up in court one day and the other judge or the other lawyer says, "Why would you use this tool if you knew it didn't have any reliability?" Right? You know better. So Make sure that the things you use have been tested and have documented reliability and validity. And then understand the pragmatics. And so this really means digging through the administration manual for an assessment so that you know how it's administered, how it's scored, and then the other kind of considerations. So a standardized test will typically include a manual, and some items have some assessments have many manuals. Others will just have a single manual. Next would be items, right? Assessments are made up of items, and then depending on how the assessment's used, you may have to do all of them, the fixed number of items, or just some subset. And then these last two parts are what make it standardized. So fixed protocol for administration. So this is how you administer items. This is how you do the assessment. There's some things here. So where you start the assessment, that's real. So right now we're just orienting to some new language. So starting points, basal and ceiling rules. Again, starting and stopping the assessment, and then instructions for administering the items. And then standardized tests also then have guidelines for scoring. So translating someone's times or tally marks, their performance into standard scores that we can compare with other people. These come in many different formats. So parent and self-report. So what are those? Surveys, questionnaires, checklists, interviews. There are all sorts of different ways to do self or parent reports. So that those assessments are asking someone, how they do or what they do, and that's distinct from a performance-based assessment, right? That's creating some type of situation or activity wherein a child demonstrates a skill, and then based on their performance, we give them a score. And so those are different. In the world of sensory integration, more than 95% of the tools that we have are parent report. And that makes sense, right? Children with disabilities have a hard time answering questions about their struggles. And yet, so that parent report isn't a measure of the thing itself, right? So if a child is having trouble with tactile sensitivity, right? I don't like to feel like a wool sweater on my arms, so I usually wear like an undershirt. So if I'm having I need to figure out where I want to seal this example. So I have tactile sensitivity. I ask a parent, how often does your child react negatively to an aversive touch, right? So wool and so the parent may say all the time, every time there's some type of aversive touch or some tactile sensation, this child has a fit. It's an explosion. So that's self-report. The performance-based counterpart to that is to actually do a sensory challenge, right? So to create some type of sensory activity or experience wherein the child's forced to confront that stimulus, and then we observe performance and score based on that.
Would you do that, knowing a child is averse to something and put them in that situation?
So to some extent, yes. So that really is just the just right challenge, right? You have to put someone outside of their comfort zone for any of us to learn, right? That cognitive dissonances, right? There has to be some type of disconnect between what I think and what I've experienced and what the world is challenging me with or what I'm learning. And that gap is where learning occurs.
So if you're putting a kid into dysregulation by doing that, then how do you filter that out of all the subsequent results that you're getting?
We'll get there, yeah. And so there's also the element of being kind and not like. So I'm not gonna spin a kid on a swing until they throw up. Like, yep, he does have a vestibular dysfunction. That's not gonna be all that helpful. So self-report performance-based. And so you see sensory profile 2 is a big kind of assessment system. And for the most part, it's self-report. It's what mom or dad or teacher says about the kid, not necessarily what the kid is actually doing. So many of these tools have kits, and the kits can get pretty complex. You'll see some of those tomorrow. Questionnaires, ecological assessments. So you might have, maybe I administer the sensory, motor, and cognitive scales to a child, but then they have observation forms for classroom, lunchroom, and hallway. And so I go and try to find people who know about this kid in classroom, lunchroom, and hallway and give them those forms to fill out. I mentioned last week, transdisciplinary arena assessment. And a reminder, that's the idea of role release. So wherein one professional would take on the assessment for all the members of the team. The Bailey scales of infant development, which we'll talk about, is a good example. It's fine motor scales that OTs very often administer, gross motor scales that PTs very often administer, receptive and expressive communication skills that speech and language pathologists very often administer, adaptive behavior questionnaires that we send home to mom and to parent, or mom and to teachers. And so the idea with the transdisciplinary arena assessment is that even though the different team members may be driving or suggesting the types of assessment, it's just one person that's going to do all of it. Two types of standardized tests: norm referenced and criterion referenced. Your text has a very nice table. So table 6.3. That's doing comparison of norm reference and criterion reference tests. An aspect of pediatric development and rehab, I think, is that we have some measures that are both, and that can be confusing both to you, for us, but also as we talk to others about our assessment tools, right? So hey, I'm going to do the this is the Bailey scales of infant development, Bailey. I'm going to do the Peabody. So Peabody Developmental Motor Scales 2. So if you say that, a psychologist may say, oh, I'm not familiar with the Peabody. Is that a norm reference test or a criterion reference test? And so what you'll see here is that it's actually both. So that may be confusing. And so how is something both? Well, if culturally we expect children to meet milestones at various time points, and we do, that fits in the criterion reference space, right? So kind of in general, say kids start tying their shoes around 5 years of age. So that's our criterion, starting to tie shoes around 5 years of age. But if we take that skill set and sample a large population, 2,000 kids, and see how 2,000 different kids do on their shoe tying, it's also normative. So just to be aware, it's actually pretty common in pediatrics. That tests could have kind of both uses. So then an implication for you would be, so if you're doing this motor assessment, Peabody Developmental Motor Scales, what's your primary kind of objective? Are you looking to see how they compare against a normative sample? Right? Is this child 2 standard deviations below the mean, and so they're eligible for therapy? Or are you just trying to figure out where they're at along the progression in terms of developing skills, where they're at and what comes next, which would be more the criterion referenced. So just zooming in on norm reference tests a little bit, all the items administered to a large normative sample. So in general, I think of large normative as like 2,000 people or so. And that's pretty common in pediatric development assessments. You will definitely see some assessments where the numbers are much smaller. And, they standardize the tool on 1,000 kids or on 400 kids, and so that's something to be aware of. How much stock are you going to put in this tool or that tool? If they have a big population to compare against, well then we're approximating the actual population characteristics, and then we're going to put more weight into the numbers. So again, that purpose is, how does the child score? What's that score like in in comparison to other kids? And then, so this will be the second time I'm endorsing either adhere to the standardized protocol and do it and claim it, or not, and let people know that. And so here's some examples of how some language I might use to indicate whether I really did this tool in the standardized way or not. So Bailey Scales of Infant Development was administered in the standardized way, or without any complications. Bailey Scales of Infant Development was administered using the standardization manual as a guide. We had to deviate due to frequent breaks. So whatever it is, just give a little detail, because someone else is going to inherit that report. Right? Down the line, 2 years from now, your report is part of records review for the next therapist. And so do them a solid and tell them whether they should believe these numbers or not. Like, for me, that's a real thing, because unless they're telling me that we did this the way that you would do it, right, that rate of reliability, then I'm going to be wary of those numbers. So a little glossary now. Starting point. So if a child is typically developing, they're 12 months old, they're walking just like we expected them to be, it would be a waste of time to spend an hour. It would be a waste of time to spend any time administering them the items that are precursors developmentally, right? So we don't need to administer the 3-month items to that 12-month-old. We don't need to administer the 5-month items or the 7-month items. So based on their age, we can determine what the starting point is. And so, The starting point might be that we start with 12-month items. Maybe it's that we start with 9-month items. Next up are the ideas of basal and ceiling. Have you encountered that language before, basal and ceiling? All right, so I think this is maybe more common in pediatric assessments, right? Again, because kids are developing more rapidly, whereas adults, by the time you're a working age adult, most of us are going to be doing the same types of tasks. There's less variance there. So the basal is the number of questions that need to be answered correctly to continue. So essentially, you calculate a starting point, and then the example here is that Bailey has a basal of 3. So the first 3 questions have to be answered correctly, or you have to earn credit for them if you're going to continue. So we have a starting point. We go to that starting point. If we get 3 in a row, we can continue. But if not, then we drop back and we go to the next earliest starting point. So if we started at 12 months and the kid wasn't able to do the 12-month items, say we would drop back to the 9-month starting point. So then the ceiling is basically the opposite. It's the number of fails or incorrects in a row that you need before you stop. The annoying piece is that assessments aren't the same on what the basal and the ceiling, what the starting or the stopping rules are. And so that just speaks to you have to know the assessment before you do it with your client for real. And remind yourself, I have absolutely administered assessments improperly because I didn't remind or refresh myself before. So an example would be stopping after 3 items as opposed to stopping after 5 items. Because there are assessments where you stop after 3. So if you kind of just get in that habit, then you're just that one little error. You didn't do two more things. Now your scores are invalid. Question in the back and then in the front.
So I was wondering, the ceiling, does it always have to be like in a row, or is it just throughout the whole assignment or the assessment?
Depends on the assessment.
Okay.
Typically, and the way that I want you to think about it is in a row.
And I had a clarification question. It says once 5 questions are missed, the assessment can be stopped. Is it can be or must be?
Good question. So can be stopped versus must be stopped. So I think there's an element of establishing rapport and maintaining a relationship and just what experience you're providing to that child. So if after you miss 5 questions, I take your sheet, right? And I say, oh, that's 5. That could be traumatic, right? And now maybe you're anxious next time you come to work with me. Maybe you don't ever want to come to work with me. So I would say I make the decision on the individual child. But if I've gotten a kid to engage for so long that they have established a basal, done some items, and now we're at I let them just finish the activity, right? So and that would be true for something timed, right? So so say we're going to score the first 15 seconds of one leg standing balance. But if the kid wants to do it for 30 or 45 seconds, fine. What harm would that be? That element of letting a kid continue and finish an assessment or go beyond, so that would be outside of the standardization procedure, but then potentially, if you have a behavioral concern or an emotional regulation concern, you might want to see how long a child could persist, let's say, in a non-preferred activity. I think most kids would say school is a non-preferred activity, right? So it's hugely relevant to childhood occupation, ability to persist in preferred, non-preferred activities. And so if I give them something contrived and a kid wants to keep doing it, that might be a good time to get some observation on what their endurance looks like or their resilience. Okay, so this is the Bailey, a screenshot of the Bailey cognitive scale. So we're just going to orient to some of the stuff that's going on here. So this is just a zoom in up on the sheet in the background now. So just a couple connections we can make. So they're saying reversal rule and discontinue rule. Think basal and ceiling. Must obtain scores of 1 on the first 3 consecutive items at the start point. So that's the 3 in a row to continue. And then stop administration when the child scores 0 on 5 consecutive items. Just to point out some of the things that are also here on the screen. So each one of these is a Bailey item. And Bailey is performance-based. So these are things that we're doing or activities and seeing how the child reacts. So this first item is calm when picked up. And so just sometime in your interaction with the baby and with the mother, you do the observe. Does this child calm down when they're picked up by the caregiver as opposed to not? So pretty simple. The A, B, C, those are starting points. So I would guess that this A is a starting point for a 6-month-old baby. And then over here you see some numbers, so 2 and then 20. That's referring to items that are linked. So the child responds to surroundings, inspects. And you see it says series here. So what it means is that those items are linked, and that if you're observing number 2, you are probably also observing performance that's relevant to number 20. And so that speaks to knowing your assessment well. There are some of these that are like 5 or 6 items that are linked. And so if you can present those 5 or 6 items kind of in a dynamic, masterful way, you can get a lot done pretty efficiently. So I also like assessments that kind of make it easy on you. So we talked about that these assessments may have big kits of things, and so what materials do you need? Are there prompts, scoring criteria? It's a nice cheat sheet. So these are PDFs of the score. Excuse me, the scoring form. This here then would be a screen cap of the instruction portion of the manual, like guide to item administration. And so this is the detail for this item. Okay, so this is the kind of stuff that was on the score sheet, and this is just a little bit more on the item. So as I'm learning these assessments, a lot of it is, I'm picturing myself on the living room floor, right? And so I've got the kit spread out, I have my score sheet, I have the manual, and then I have the materials that I'm like actively using for an item. And learning these assessments is just a lot of back and forth, right? Okay, what's the next item? What materials do I need? Okay, how do I administer the item? All right, how do I score the item? And just kind of that back and forth process of checking. So these assessments result in scores. A raw score is what it sounds like. items added together, and understanding that items are created by people. And so a raw score the raw score is totally susceptible to reliability and validity, right? So it's important that that items are conceptually related. You know, if we had let's say a measure of depression, and I asked you, have you been sad in the last 2 weeks? Have you contemplated suicide in the last 2 weeks? You've been socially isolated, and then like, do you like margaritas? But do you like margaritas isn't part of that same construct. I mean, drinking and depression are probably related, but that's another thing. So adding that margarita number or score into a raw score doesn't make it legitimate. So if you're looking at an assessment and you're looking at the items and they don't make sense to you, that becomes part of your interpretation, right? So maybe you get a score and maybe you're just not going to pay attention to it because you don't like the scale, or you don't really think that these items are all that related. So raw score is just things added together. This is so annoying because we can't decide on our language, right? So standard score, I already defined it differently just earlier this lecture, didn't I? So this is from the Peabody Developmental Motor Scale, and they like to be different. So they use the language standard score. Their mean is 10, standard deviation 13. And you see there's a little bit of discrepancy around interpretation too. So that average range around 10 would be 7 to 13, yes? 68% of a sample would score between 7 and 13. So just another kind of annoying thing is that some assessments, Peabody, they just decide to make it 8 to 12. So that's more like a 50% sample. So you have to know what terms or kind of elements are at play here, and what the norms are for a specific test. Some tools allow you to combine subtests into a composite. And so Peabody, again, as an example, we had object manipulation and fine motor together to get a fine motor quotient. And the idea is that makes sense conceptually because the object manipulation test, which is mostly actually about like ball skills, throwing a ball and bouncing a ball. So that's object manipulation. Actually, the other one isn't fine motor, it's called visual motor integration. And that's much more about snipping or using a crayon or a pencil, and can you put a puzzle together. So the idea is that things like ball skills, motor coordination are conceptually similar to visual motor skills, cutting, drawing, puzzles, so we can combine them into a motor quotient. So similarly, you might not buy that those things really all go together, right? So look at the skill sets here: grasp, object, stack, blocks, draw figures, manipulate objects. That's the ball bouncing, right? So does one number, we can boil that down to one number. Does one number communicate what there is to say about your or a child's skill, their performance in all those different areas? Right, so that's, I'm trying to share, right, this will generate numbers that we can use, but it's your job to evaluate and think about those numbers. And then percentiles, right? So we're talking about comparing one person to a sample or a population, so we can generate a percentile rank. Some additional ones. So a z-score is essentially a way to talk about standard deviations away from the mean, essentially. So a child that gets a z-score, you see here, of negative 1.66 means that they're 1.66 standard deviations below the mean. So some assessments, kind of the final output will be a z-score. This is back to that language thing, standard score. Peabody is calling it a scaled score, typically 100, standard deviation of 15. So if you just like put an asterisk in your brain, scoring for the Peabody is a little bit different. That's enough for now. T-score, another way to present a number, mean of 50, standard deviation of 10. An example that's used in the PDCAT, so Pediatric Evaluation of Disability Inventory, Computer Adapted Test. So I do like this figure because I think it's a way to integrate these different concepts kind of all together. So, so at the top you have the percentages that would be within each kind of section, each standard deviation section of this graph. And so then those are lined up with the standard deviations. You know, you can do pretty quick percentile rank estimations if you know where someone falls on a standard curve, right? So that person whose standard score is 100 is at the 50th percentile in terms of performance for a person their age. And that's what you're seeing right there. So z-scores, so z is going to look just like standard deviations. T-score is a little bit different. Again, because the mean will be 50. So I would encourage you try not to be overwhelmed by this stuff. I think most Americans probably don't think about standard deviations in a typical day. So if it takes you a minute, that's fine. That's normal. Pretty much every time I open a stats book or program, I'm reteaching and relearning something. And so as you become more skilled with assessments, you'll become more comfortable with this stuff as well. So then we report our scores. So this is a Bailey record form, and we'll zoom in on some of those, some of these things that we've talked about. So the first column from left to right that you're seeing are raw scores. And so you can also see here that we have raw scores for 6 subscales. So there's a cognitive subtest that stands on its own, 2 language subtests that are part of a language composite, 2 motor subtests that become a motor composite, and a social emotional subtest. So raw scores to scaled scores, the way that we get from raw scores to scaled scores is to go to the manual, and in the back of every manual, it's usually the back, are the big data tables, right? And so you go, you find the age range for your kid. This is a child 3 years, 3 months, and 21 days. You go find that table, and you look up, you take the raw score, cognitive raw score 14, and it provides you with a conversion. So that converted number, the scaled score then, is something that you can then start to interpret in the context of the normative sample. For some of these, there are composites. And then, so Bailey is also providing a percentile rank and a confidence interval. So I'll be honest. I stop at composite score. I am uncomfortable usually reporting percentile ranks and or age equivalencies. We'll come back to that. And so why? Because I think those metrics, a percentile rank or an age equivalency, have more emotional weight, let's say, than communicating how a score compares using a descriptor like average or below average. So I'll come back to that, and we'll talk more about it in terms of how we report these results. I think it's hard for a parent to, they know something is going on with their kid, right? That's why they went to the doctor, or why they went to their teacher, and that's why they had a referral to CSU. They know something is at play. They don't need us to tell them that. So if then we come out of our evaluation and we say your child's in the first percentile, it hits hard. Whereas if you say, as we suspected, Bobby was in the below average range, right? I think that is a little bit easier to palate. Now, yes, like the numbers and the language we use are linked, and they're equivalencies, and so if somebody wants that information, we provide it and then try to help explain it. So similarly with an age equivalency, right? If we have the 7-year-old kid who's in our eval room, in my experience, a parent does not want to hear that 7-year-old is like a 2-year-old, 2 years, 3 months. That's too much, right? In my experience. So criterion reference assessments, aka curriculum, and again, these are expectations that we have in terms of skills or abilities that kids have by different ages. So these are nice because they're less about does the child have 20 degrees of extension or flexion in their finger. They're about occupations. So they're about things that everyone on the team cares about. Absolutely valuable for goal writing, especially with kids. If we're talking about a developmental sequence for dressing, where are we at now and what comes next? This is the list of what comes next and in what typical sequence. So it gives you guidance on how to support developmental growth. An example is the Hawaii Early Learning Profile. So very often used to check eligibility for early intervention or for birth to 3 settings. So it's the set of skills that babies birth to 3 should be achieving. And so we can assess where a baby's at, and then we have that starting point in terms of where we go next. All right, so kind of back to some of the ethics or being culturally sensitive around what we do with these results, with these data. So that first one, maybe the child performs lower than expected, right? So maybe parents brought the kid in because the teacher told them to, but they're like, we're sure it's nothing, but then it is something. That absolutely can be that could be an issue. What if child smack dab in the middle of a normal range, but parents still want therapy? That depends a lot on the context and funding, right? So if a family has health insurance, you can probably have as much therapy as you want within the context of your health insurance plan. 20 or 50 visits a year for OT or rehab usually. You can pay out of pocket. In the schools, you may meet criteria for a eligibility area, say autism or a developmental delay. But if it's not impacting your educational performance, you're not eligible, right? So you might be in the normal range.
Did you come into that situation in outpatient? I mean, I think there's
Outpatient, yes.
a handful of us at schools, and I had parents that were like, my kid needs an IEP, but at least you have a lot to like fall back on. That's like, we can do this. But outpatient, that would make me wonder why they're so.
Yeah, so absolutely much more common that I would see someone in a normal or above average range in the context of an outpatient, right? So people using their private health insurance benefits or private pay.
Really?
That would be the population of people that are interested in that would be pretty skewed on socio economic variables, right?
Sure.
Yeah, normal range, but they still want therapy. I mean, if they're willing to pay for it, and the goals are legit, like yes, I could help someone progress to above average. Like we can do that too.
But ethically, do you have the responsibility? I'm sorry.
No, I was laughing.
No,
Do you have the responsibility to kind of put them on hold if there's another client in line with greater need? Like if your caseload is full or almost full, one's not enough.
Yeah.
Kid in need, kid not in need. Can you just literally say to them, "There's someone ahead of you. We'll let you know when we have an opening."
So yeah, so practically yes, right? If you're a sole proprietor, private practice, you can only take on what you can take on. So within yourself, if those are value judgments or decisions that you make, I think that's fine. I think most of the time in a private practice type setting, therapists are eager to provide service, and it's easy when parents are eager to pay for it. So, so there's an opposite of this that's also kind of true. Child is capable of normal range performance, but their actual application, what they actually do, is below average. So that's actually the definition of a learning disability, of which I have one called dyslexia. Right, and so you have dyslexia.
I do. Yes. That's a breath right there.
So for what it's worth, if I ever say a number and you think I maybe flipped it, I do it more with numbers than I do it with letters. If you think I maybe flipped a number, it's fine to ask me, did you mean to say 51 or did you mean 15? I will not take offense to that at all. Right, but so if a child has average, let's say, intelligence, But what we observe in class, their performance and their standardized testing, their output is below average. That discrepancy is the definition of a learning disability. Right, plateaus, that's a big thing in the public schools because the model is totally different. We only have to write a plan of care, an IEP, so the Individualized Education Program, once a year. So we have to review the plan once a year, and the government's paying for it, and there isn't all that much oversight. So kids get continued on quite a bit when they've plateaued, maybe when they've overcome their original issues, and that can be a challenge as well. Ooh, family disputes the validity of your assessment. Right, if you come into the meeting and you report your numbers and you're like, yeah, I'm confident in these numbers, right? And then the mom, who's a clinical psychologist, says, that assessment has poor reliability. So I've had that. I've had professionals call BS on me on my assessment results in meetings. It stinks. So you want to make sure you have your ducks in a row. A couple more things to think about: positive, solutions-oriented language. So strengths-based. Every time I'm reporting results of an assessment, strengths first, challenges second, plan to move forward third. Right? So I'm never throwing, I'm never starting with a negative. And if you're having trouble, just say they have big, beautiful eyes. Right? You have to start with something positive and keep a family on your side.
The parent does or the child does?
Yeah. Well,
First of all, your child has beautiful eyes.
yeah. I didn't think of saying that to I have never started off an interaction with a parent saying, boy, you have beautiful eyes. Okay, so strengths first, yes, deficits, but potential, right? So the brain is incredibly neuroplastic. We're capable of huge amounts of change. And so, yes, we may be having an issue that may be a big deal now, but I can help you move forward, and I have a plan to do it. Be honest and truthful. Yeah, and that, right, try to break things down, keep it simple. So functional recommendations, family, teacher, priority, service delivery model. I think making sure those things are aligned is important too. So, yeah, making sure those things are linked and thoughtful. The teacher may have one priority. We may need to address that priority at home, but if teachers and parents aren't aligned, it's going to be hard to figure that out. All right, so this is now context, more standardized assessments, and in the context of your Packer assignment. Packers. It's all right. So we're going to learn about many assessments, some much more than others, some not at all. You will develop this compendium that we'll combine and then share with everyone. These are the ones that are in your book. So out of the whole world of pediatric assessments that are within our scope of practice and available to us, these are the ones that the authors of the Peds OT textbook filtered out and said, we want to make a table out of these, right? So table 6.3, it's 2 pages, 165, 166, just some of the essential components of these assessments. You do not need to memorize all of them. Again, do not memorize all of them, all of this. there are some essential features and some ways to go about learning and studying the stuff that I do think makes sense, right? So you can group, you could group or think about some of these by domains tested. So if we look at domains tested, that first one, Bailey scales of infant and toddler development, that's what we've been talking about the most so far. They didn't put the names of the scales there. They put the actual domains, right? So, oh, we only have the fine motor and the gross motor. So you actually know that there's more to the Bailey now than what the authors of our text put in this table, right? There's the language scales, there's the cognitive scale, and there was the social emotional scale. So one way to think about this is if I want to assess a domain area, for example, fine motor skills. So if I want to assess fine motor skills, what are some of the assessments that are available to me? And then how, then you can break them down a little bit more from that. So I'll talk through this fine motor example a little bit more. So I hopefully can give voice to what I'm trying to talk through. So I want to evaluate fine motor skills, and depending on the child's age, I'm going to pick a different assessment. Right? So if the kid is between birth and 42 months, right, 3.5 years, I'm probably going to the Bailey. So Bailey has fine motor, and I also like that it has kind of those other big domains that are very relevant to infant toddler development. Let's say now I have a 5-year-old, so a kindergartner, and I want to look at the kindergartner's fine motor skills. I have to look at some different options. Bailey no longer works for the 5-year-old, right? So if I use the Bailey with the 5-year-old, I would say using the standardization manual as a guide, but because he's outside of the age range, these scores should not be interpreted as standardized. So for the 5-year-old, I have some different options. So I have Peabody developmental motor scales, that would catch a 5-year-old. I have and so there's also a fine motor skill there. There's the Miller function and participation scales, or MFUN. That has a fine motor and visual motor, tests. And I like this one, and it's kind of in the name. I like this one because the skills are embedded in occupation. So the test for like using a scissors is like an arts and crafts activity. So you sit down at the table with a kid and you do an arts and crafts activity. And so while you're doing that, you watch how they, cut with the scissors and how they're using their supporting hand. And then, it's punch holes along the edges and then strangle it. So you just observe performance in the context of an occupation, which I like. So you see that performance-based. 5-year-old, I could also use the Brunings. This one's a mouthful. Brunings Osoretsky tests a motor proficiency. This one has a fine motor control scale. It also has a fine motor precision scale, manual coordination. Right, so same domain, right? The language is a little bit different. Fine motor control, fine motor visual motor, fine motor scale. It is the same domain that we're talking about. So I like the Brunings. This one went up all the way through 21. So I could use that all the way up through middle school and high school. Which, as you look at this table, you'll see, and it makes sense because kids are developing more rapidly when they're younger. We have fewer tools for the older age range, right? So this one, Miller Fund, goes up to 7 years, 11 months. Brunings, 21 years, 11 months, 7 years, K6. So there is a little bit of a sort, right? what's the best tool for this kid at this time? Realistically, I think a note card. If we're talking about how we study these and think about these bigger, higher priority assessments, a note card worth of clear, concise information is probably enough on these, right? So if you have PDMS2, you say to yourself Peabody Developmental Motor Scales, and then you just start doing a little thinking, right? This is one for kids 1 to 84 months. So these are the ones that are in the book. Tomorrow at 7 a.m. we're going to launch the PBL and Packer assignments. We'll talk about those in lab tomorrow. So you'll have 2 weeks to dive into an assessment or two. Some assessments are bigger than others, so dive into an assessment with a partner, and it's a one-pager front and back kind of thing. Five-year-old's back. So the 5-year-old presents to an outpatient clinic with concerns around holding the crayon or pencil, so pencil grasp, in school, and difficulty throwing objects. Which standardized assessment is best to use with this child? So I realize you don't have this stuff in your brain yet, but we just talked about Bailey scales. Does anyone remember the age range for Bailey scales? 42 months, right? So it's not going to do it for us. Pediatric Evaluation of Disability Inventory. So you don't know this yet. Has 4 scales. There is a self-care skills scale. There is a mobility scale, a social function scale, and a responsibility scale. What you didn't hear me say was motor. So there's mobility, and it certainly has gross motor things in there. And we have ADLs, and those ADLs certainly have fine motor components. But PD does not have a motor scale. So if we have a concern about motor, that's not the tool. Peabody is. So let's take another 5 minutes. Actually, we'll do 7 minutes this time. So we're making really great progress today.